mountains, something different could have been done in order to prevent harm. So that's the area that we like to focus in. We call them missed opportunities in diagnosis. We like to sort of think about where we can make a difference in studying the problem and improving the problem. And so we like to focus on areas A and B, as you can see on the slide. And we want to specifically focus on situations when there's harm. And the harm could be from either delayed treatment or a delayed test or a wrong treatment and a wrong test. Not all the diagnostic delays can be prevented, but many of them can be. Next slide. So what are the types of conditions that can be commonly seen for diagnostic errors? The problem is there are a lot. So there's 10,000 different types of conditions, and almost all of them could be misdiagnosed. So these are some of these studies that have shown that the types of diagnostic errors, the types of conditions are immense. So you can have misdiagnosis of cancers, heart attacks, strokes, congestive heart failure, psychiatric conditions, infections, perforations, surgical conditions. So the list goes on and on. So it's a really, really big number of the types of conditions that can be misdiagnosed. You go to the next slide, please. So the themes from our research studies over the last couple of decades mainly has shown that it's the common conditions that get missed. It's not just the rare conditions. It's not just what we call the dilemmas that get missed. It's the common conditions that get missed, the common cancers, the heart attacks, strokes, infections. It's the common things that get missed. The second theme that comes from our studies is that the missed opportunities that we find are often related to some type of a history and exam finding. That means in the Rory Staunton case that I showed you, his physical exam findings were missed. So we find this very commonly, that there's some history taking or some physical exam finding that is missed and the test is not ordered next. The second big finding of why these things occur is sometimes the information is buried in the electronic medical record or just in the paper-based record. So that patient may have some abnormal finding, such as a chest x-ray or a blood test, but it's not being looked at by anybody. Next slide. So what are the contributing factors? Next slide. There's a lot of things that can lead to diagnostic errors. Biases, heuristics, communication problems, data gathering issues, like I told you, follow-up of issues, follow-up of abnormal tests, language issues, knowledge issues, doctor overconfidence. There's lots and lots of reasons why this can happen. Next slide. So another thing we like to sort of think about is, uncertainty. Should I order the test? Should I not order the test? Doctors frequently face this uncertainty in daily practice. If I order the test, I might be harming the patient and it could be very costly. If I don't order a test for this symptom, then maybe I'll miss the diagnosis. So we're always trying to balance this. So this sort of uncertainty often also leads to, patients sort of progression and maybe getting a misdiagnosis because we're not sure sometimes should we order the test or not. Next slide. So the way we define diagnostic excellence is it's not just about making a correct and timely diagnosis. It's also making a correct and timely diagnosis using the fewest resources. It's not good for me to order a CAT scan on every single patient that comes into my clinic with a headache. It's not good for me to order a CAT scan on every single patient that comes to me with abdominal pain, a belly pain, right? Because then I might be over-testing and harming. So making a diagnosis using fewest resources while maximizing the patient experience, while making sure that we communicate the uncertainty that we have to patients, managing that uncertainty, and then sometimes waiting to see what happens so we don't harm patients unnecessarily. All of these factors are essential in the definition of diagnostic excellence. Next slide. So we recently published a paper to think about what are the things that doctors could do in terms of making diagnosis better and achieving diagnostic excellence. And we put one of the ones that would be very important to you all, which is making diagnosis a team sport and engaging patients as one of the big strategies. Next slide. So this is one of the recommendations that also came out of the National Academy of Medicine report that I talked to you about. How do we improve teamwork? So one of the things that we've been trying to do in our work is to learn from patient narratives. So this is a study we did with Helen Haskell and a group, is how do we learn from patients who've been misdiagnosed? We studied 183 patients who had been misdiagnosed. And what we found was problems related to the doctor-patient encounter, the interaction, was a major contributor to diagnostic error. We also found a lot of behavioral and interpersonal factors that were leading to diagnostic errors. And one of the things that we found out was one of the most common reasons that patients told us that they were misdiagnosed is because they said the doctor didn't listen to me. And that was one of the most common things that we found in our study. So, and these kinds of perspectives from patients can really help us understand where to make a difference, because we don't get these types of reports from doctors, right? So getting these reports from patients really enhances our understanding of the problem. Next slide. Okay, so what are the patient priorities? So we also have engaged patients in how do we do research, in what areas do we do research in? So we got a panel of patients together and we asked them, can you tell us where do you think we should prioritize our efforts in research? And of course, you can sort of think about that coordination communication was number one. But what I want to talk about is number two, that patients told us, you need to research how can health systems accurately track and report diagnostic errors. So I'm going to give you a little examples of some of the things we've done in that area. Next slide. So one of the recommendations that came out of the National Academy of Medicine report that I told you about is that they wanted healthcare organizations to have these very similar monitoring systems in place. So we can monitor the diagnostic process, monitor diagnostic errors, and learn from them in some kind of a timely fashion. And if you look at the next slide, so basically what I'm trying to say is patients told us this, but also the National Academy was telling us the same thing, that we need to have at the health system level some tracking mechanisms so we can learn and figure out, about these diagnostic errors. So this is a model of care. It's called LEAD organization, and LEAD stands for Learning and Exploration of Diagnostic Excellence. So over the last 5 years, we've tried to develop this model of care at the health system level, where a health system invests in resources, time, people in order to learn and explore diagnostic excellence. So you need to have systems in place. You need to have a person in charge. So that's why you see the blue in the center. If you don't have a coordinating hub of some kind, an organizational hub to coordinate activities, nothing will get done, right? So if nobody's in charge, nothing will get done at the organizational level. So every organization, every health system could have an organizational hub that coordinates activities around it. What are those activities? One is we need to learn from research. So all of these research findings that I'm telling you, a lot of them have to be implemented in practice. We need to figure out how to make practice better by taking research and putting it into practice. Second is you need to measure for improvement in learning. That means we need to figure out what's going on in my organization, what types of safety events are happening, how can we make it better, what do we do about them? Thirdly, we need to create an accountable culture of engaging and learning from patients, which is exactly what we're talking about here. And then lastly, we have to engage clinicians too, because they are the ones ultimately who are responsible for making a lot of the diagnosis. So we need to engage them in activities also to improve diagnosis. So if you can create this organizational model of these 5 things, we can make advances towards diagnostic excellence. Next slide. So what about leveraging patient-reported data? So I gave example of one study where we talked to patients who had been misdiagnosed and we learned from their narratives. But there are other ways too. A lot of organizations are collecting patient complaints right now, but many of them are not looking at them from the patient safety perspective. They are just thinking about all the other types of issues, food and transport and parking. We need to be investing more about learning from patients and their patients' grievances and complaints directly. So all organizations need to invest in learning from patients and patient complaints, but looking at the safety data. We're also looking to see with the open notes movement, where in the United States, at least, all the medical record is now open to patients, and patients can look at their medical record and see, oh, wait, this is not my medical record, or I never had that surgery, oh, my diagnosis is not correct. So we're now also trying to engage patients so that patients can look into their medical record electronically and comment to see, is there something wrong? So we are trying to do that now so that patients can get more engaged by looking at their own record, because they can access all that information now. So Open Notes is coming to United Kingdom. I believe that other countries are going to follow that as well. Next slide. So here's another model. I'm a researcher, so I like to show models and pictures just to sort of show and think about what I'm thinking. And this is another picture, is that of a learning health system. What's a learning health system for diagnostic safety? What's a learning health system for diagnostic error? It's in which you collect data, you learn from it, and then you put into place some actions to improve. So what we need to do is patients can play a role in every step of this learning health system. So if you think about, I want to initiate an activity to learn and improve from diagnostic error. The first thing we have to do is to do a risk assessment. I'm going to show you how you can do that. Then we have to gather and analyze data from learning opportunities. We call them learning opportunities because they're essentially missed opportunities where something could have been done differently and we can learn from it. And then you need to take actions to change practice. And that's what makes a diagnostic safety learning health system go forward, because you learn from data and then you put into place some actions to change practice. And everybody needs to be involved: clinicians, policy people, health systems, patients, and patients can play a role in every step of this learning health system. Next slide. So this is the example of the risk assessment checklist that we recently developed, where we could use like a 2-page document. It only has 2 pages of practices, 10 practices, 2 pages, and we want the health systems to do a risk assessment to figure out what are they doing to improve diagnostic safety. This is before any errors have happened. This is before any misdiagnosis have happened. What kind of infrastructure, what kind of practice pattern does a health system have so that they can improve? So these are 10 practices, and I'll show you a couple of examples from this checklist. Go to the next slide. You can see, next slide. Here's one that you can see. A healthcare organization actively seeks patient and family feedback to identify and understand diagnostic safety concerns and addresses concerns by co-designing solutions. So you can figure out if your health system or your hospital that you go to uses a SaferDX checklist to understand how they are performing. And you can ask them whether they are putting into place this practice. Next slide. The next one is healthcare organization encourages patients to review. If you go back, I'm just going to quickly read that slide. Review their health records and has mechanisms in place to help patients understand, interpret, and act on diagnostic information. This is exactly what I just talked about, that patients should be encouraged to review their medical record. Next slide. So here's another resource that we developed that helps organizations collect data on diagnostic safety events. That means organization has a system in place to learn from diagnostic errors, review them, and then put into place some actions. This resource was just recently released by AHRQ. We helped them develop it. Next slide. It has several types of strategies in which the healthcare system can, if you go to the next slide. So the health system essentially can figure out how are they going to collect diagnostic errors, how are they going to study them, how are they going to analyze cases. It has a very practical tool or a practical resource that can help an organization or a hospital or a health system or a clinic figure out how are they going to collect and study diagnostic errors, and they're going to learn from them. Next slide. And here's a toolkit that AHRQ also released that can help engage patients to improve diagnostic safety. You know, I'm not going to go into this in detail, but the resources are available to you. Go ahead and Google them. Figure out if this is something that you want to use, you want to learn, you want a health system to use. They're all free and they're all available to everybody. Next slide. Okay, so here's what I want to summarize. What are the next steps for us? Number one, we need to test and use novel methods to engage the patients to improve diagnosis, but also to reduce diagnostic errors. Remember, they're related, but they're different things. We need to reduce diagnostic errors, but we also want patients to be engaged to improve diagnosis. Number two, we need to gather information from patients to learn about what's happening. What are the risks? What are the events? We want, remember all those complaints, all those narratives that we can learn from, we need that as well. And then lastly, all these tools that we are developing, they're coming from research. We need to be able to use them to put into place actions to improve and change practice, to improve and change policy. So all these tools and strategies that we're talking about need to be put into practice. That's very important, because otherwise they're just going to be sitting on the shelf and nobody's going to be doing anything about it. And that's all I've got. I want to thank my funders, which is AHRQ, the VA. If you go to the next slides, I think I have a list of funders. I always thank my team that helps me do research. And back to you, Helen. Thank you so much for having me.
Thank you, Hardeep. That was great. And our next section of the webinar is going to be patient accounts presented by Nagwa and Margaret. I'm going to introduce this with a little brief background on patient engagement and diagnosis as I've observed it over the years, although Hardeep has certainly covered it really well already. Next slide, please. So, as Hardeep said, communication, shared understanding, the relationship aspects are what generally matter the most to patients. Next slide, please. First, I want to also give you a little background on me. You're going to be hearing stories today about two mothers. I'm a mother too. This is my son, Louis, who died in a hospital at age 15 from an undiagnosed medication reaction. Because of what happened to my son, diagnosis has been a big part of my work in patient safety over the years. So Louis is the reason I'm here, and I like to pause and remember him every time I give a talk. Next slide, please. So Hardeep's given you a terrific overview. As I said, for many patients, diagnostic errors are primarily grounded in the personal encounter, communication issues, dismissive attitudes, preconceptions, assumptions, those really loom large. Poor care coordination is a major problem for patients, as you probably can all attest. That's especially the case around diagnostic testing, which can be a little microcosm of all the things that can go wrong in a health system. And then the absence of a rigorous systematic approach to diagnosis can drive patients crazy. People anchoring on a diagnosis, not being open to change, and then repeating the same mistakes again because they have not gotten proper feedback. There are many reasons for these shortcomings. Hardeep's laid out a lot of them, but we still have a hard time overcoming them. Next slide, please. So I think most of us in the diagnosis community believe that effective patient involvement is really the strongest single antidote we have to these problems. The problem with implementing patient engagement is that it's also provider engagement. Both parties need to be trained, prepared, and receptive to each other. That's a bigger undertaking than it might seem. It requires more than just goodwill. It includes significant changes to our educational system, which I don't believe we've really talked about. But we do have tactics we can use in the moment, such as structured communication techniques. These are some of the ARC tools that Hardeep was talking about, and we'll put these on the website. Learning to listen deeply, being sensitive to cues, keeping an open mind about uncertainty. Next slide, please. And uncertainty is one of the big issues upon which diagnosis falters, I think. Everyone craves certainty. Many healthcare providers, especially young ones, believe that conveying an air of certainty is an important part of being a professional. So patients need to learn not to expect that. They need to realize that diagnosis is an ongoing process and that it continues to evolve and change as it goes on. And they also need to realize that their continual input is required and that they should step up and take up that role, even if they're not asked to do so. Next slide, please. The slides will be on the website, so I'm not going to dwell on these precepts. I'll just say it's important to be prepared for healthcare encounter. Organize your thoughts, do research beforehand if you can, so you really have an idea of what you'll be talking about. Keep written records. You're probably the only one who will have documentation of your entire healthcare journey. And make sure that you and your provider are on the same page so you can understand their thinking about the diagnosis and the plan and what you are capable of. Next slide, please. Finally, some resources. The Society to Improve Diagnosis in Medicine, improveddiagnosis.org is probably the best repository of resources on diagnosis. This is their patient toolkit, which has some tips for preparation, questions, a whole lot more. I encourage you to have a look at the improveddiagnosis.org website. And that is it from me. Next slide, please. Next slide, please. So next up, we have Nagwa Matwali, who will present a doctor's report of a case of misdiagnosis in Egypt with comments from a patient perspective. Nagwa's worked for many years as an independent patient champion in Egyptian hospitals, especially in the women's section. And this case involves a tragic occurrence with a young mother and her infant. Nagwa?
Yes, Helen, thank you. Can you hear me?
Yes, yes.
Okay.
Next slide.
Well, it seems that most of the errors is common all over the world, but I will present my case here. It's about the mother and the child who were very bad, wrong diagnosis, and they lost their lives. So next, please. Next slide, please. Okay, it's a 20-year-old woman who is in the 7 months of her first pregnancy. 1 week ago, she was found to have elevated blood pressure and protein in urine, which she was diagnosed with mild preeclampsia and prescribed hypertensive treatment. Next one, please. 1 week, okay. When when the doctor went, this is the next one, I think, there's, okay. When the doctor saw her in the hospital when she came, she was holding the side of her head and said, "I have a severe headache. I feel my head will explode right now into pieces." Next one, please. When he asked his nurse about her vital data, her blood pressure was shooting high as 180. It was clear that Mrs. S.H. condition has progressed to severe preeclampsia. The next one, please. One day, okay, the severe headache she is experiencing is worsening, as it might indicate an impending life-threatening eclampsia. The next one, please. Within 2 minutes, her body was shaking and her back was aching, and for a whole 1 minute, she was then unresponsive and lost consciousness. Next one, please. In view of her condition, an urgent cesarean delivery was done. She gave birth to a child and who needed an ICU admission. Next one, please. However, she remained unconscious for the next 3 days. The CT shows sign of brain hemorrhage, not eclampsia, and this was missed for 4 days. Next one, please. And after 1 week, the mother and the baby died in the ICU after 2 days. It was sad. Next one, please. What were the pitfalls in this case? When she was suffering from the headache, and this severe headache, the careful attention was not given to the patient complaint. Brain hemorrhage typically presents with headache that the patient describes as the worst headache she had in her life. This is the first mistake. Next one, please. And the next one, to keep the case fitting is assumed diagnosis. The doctor ignored some signs, did not search for others' character of headache. Neurological examination wasn't done. Next one, please. and this is the second one. Also, the patient lost when she lost consciousness after 2 minutes and became silent. No effective communication was done with her relatives. This might have drawn more attention that the patient's main complaint was unbearable headache. And here we come to the engagement of patient and relatives. This would help very much to save her life. Next one, please. Defective problem-solving skills. It is uncommon for eclamptic patient to remain in coma for days. The doctors neglected to go back and rethink their own diagnosis. Even when she signed, the sign began to point in a different direction. This seems simple, but it's difficult for most of the people to do. This is when we come to the overconfident, which was mentioned previously in your presentation. The doctor is overconfident that he thinks that this is a normal case, that he got through every day and couldn't be more than that. Next one, please. And the neurological consultation was very, very late. There was delay in 2 days for this consultation. Because of this delay, maybe it could be in our country due to the lack of proper digital registration. And this is missed in our hospitals till now. Next one, please. The public hospital especially. And then the lack of equipment. Due to the early of the condition CT scan facilities, we don't have the proper equipment like the ICU in all the hospitals, especially the hospitals of the gynecologists, because we don't need it much. But this was wrong. We should have this equipment in every hospital. And I think they are thinking about that in the future. Next one, please. This is the case which I'm giving an example what's going on, one of the diagnosis errors in Egypt. And I think if we go through all these medical errors, which has been done for this case, I think it's common, like everyone was mentioning in all your presentation. It's the wrong diagnosis. They didn't give the time to listen to the patient so they can know more of the symptoms. They didn't think twice about the diagnosis. They only took it day by day. They didn't think of the whole picture so they can give more correct diagnosis. The other thing that they didn't communicate with the parent, and all this together. And I think we should very much look for all these things and how to deal with them so we keep all the patients safe. Thank you.
Thank you. Thank you so much, Nagwa, for that moving case. Can I have the next slide, please? So our next and final speaker, last but not least, is Margaret Murphy, who is going to tell us the story of her son, Kevin. Please go ahead, Margaret.
Next slide, please. Next slide. In the 3 years prior to his death at age 21, the patient, my son, Kevin Murphy, engaged with multiple healthcare professionals at every level of the Irish healthcare system. Considering that the many diagnostic tools available were not used or were incorrectly interpreted until too late to be of benefit to the patient, it is not unreasonable to conclude that every point of contact in that system failed him. It is not acceptable that for a definitive diagnosis to be made, communicated to the patient family, that family has to await receipt of an autopsy report, as was the case with Kevin. As Kevin's mother, I recall voicing my real concerns to the GP about Kevin's progressing uncharacteristic behavior sometimes including aggressiveness, again uncharacteristic. His lack of energy, lack of motivation, and neglect of his studies. The doctor's response was, Margaret, in 4 years' time, you will look back on all of this and laugh. Clearly, he considered that this was a late teenager who was exercising his newfound, almost adult autonomy. 4 years later, we were regularly visiting Kevin's grave, and there was no laughter. Clearly, he did not take my concerns seriously, and I would say you ignore at your peril the concerns of a mother. Next slide, please. When Sir Liam Donaldson, chair of the World Alliance for Patient Safety, was made aware of the detail of Kevin's patient journey, he immediately identified the many opportunities to save his life, all of which were missed, and caused Sir Liam to liken this patient journey to a manifestation of Jim Reason's Swiss cheese model. Missed opportunities, which included that when Kevin was 1 year into his journey, he complained of severe bone pain, even when at rest, cognitive issues, lack of concentration, inability to study, and brain fog, coupled with an insatiable thirst, while his family reported mood changes, accompanied by uncharacteristic and unacceptable behavior. Will you excuse me? That's the landline. Thank you. Brain fog and the insatiable thirst, while his family reported mood swings accompanied by uncharacteristic and unacceptable behavior. When referred to an orthopedic consultant, blood tests revealed high levels of calcium at 3.51 millimoles a litre, a level which required immediate referral to endocrinology. That referral did not happen. Slide 3. Next slide. When adjudicating on the quality of Kevin's care, medical experts later stated that the combination of bone pain, hypercalcemia, and renal failure points either to a diagnosis of primary hyperparathyroidism or metastatic malignancy, and these ominous results should have been investigated as a matter of urgency. And from another, all the evidence indicates that the patient was suffering from a solitary parathyroid adenoma at the time. Removal would have been curative with a normal life expectancy. And yet another, Kevin would have had surgery to remove the overactive parathyroid gland. He would have been cured and would still have been alive today. Next slide, please. Shortly before his death, the GP, who we later learned had experienced success in diagnosing leptospirosis in young patients, became a victim of confirmation bias and only considered this condition for Kevin. Experience can serve you well, but in this case, it caused tunnel vision. The practice nurse who had taken the telephone conversation from the laboratory wrote the new blood test results on this post-it note, showed it to the GP, and as a result of that conversation with the lab, offered the correct diagnosis of hypercalcemia. Ignoring that input, the GP wrote his letter of referral to the hospital, filtering the results and only including in the letter his own diagnosis and making no reference now at 5.73 millimoles a litre. He did, however, include the post-it in the envelope. When compiling his file in the hospital, that post-it was stuck to the back of the referral letter and not seen until 6 weeks after Kevin's death. Next slide. And another incorrect diagnosis of nephritis was made this time. Nephritis was a symptom. It certainly wasn't the underlying condition. While Kevin is now adding to his symptoms by reporting muscle pain and neurological problems, and I quote him, "I have crazy thoughts coming into my head." He was then transferred to the renal unit, not endocrinology, in the local tertiary training hospital, where he was managed solely at resident level, without senior input or knowledge of his deteriorating condition, with his calcium now at 6.1 millimoles a litre, a level since described as inconsistent with life. Hours later, Kevin died as his sister and I sat at the bedside. His death certificate lists multi-organ failure, hypercalcemia, parathyroid tumor. Next slide. Atul Gawande tells us that more than anything, the great from the mediocre is not that they fail us, it is that they rescue more. Maybe that's the piece that needs to change, that we concentrate more on rescue and being rescuers. And diagnostics is the ultimate rescue tool. It is abundantly clear that at many points during his patient journey, Kevin badly needed someone to rescue him, but no one came to his aid. Next slide, please. In summary, there was the inability to recognize the seriousness of his condition, discounting family concerns and absence of direct communication with the patient. Appropriate and timely interventions were not taken, with no tracking of deterioration. There was selective and incomplete transmission of information, including seriously flawed handovers. There was absence of an integrated pathway. The link between family reported uncharacteristic behavior and test results wasn't made. His developing neurological problems were ignored. His treatment solely at resident level without consultant intervention or internet or alerting the on-call consultant to the calcium levels in deterioration. Consequent damage to the level of trust and confidence, and also in particular individuals. That trust and confidence back to normal. So I thank you for bearing with me, and I thank you for considering Kevin's patient journey. And I particularly thank you for the invite to be with you today.
Thank you so much, Margaret. It is an unforgettable story. We need to, next slide, please, Harris. Next slide, please. Okay, we need to all take a deep breath and change gears for our panel discussion. If everyone who is not on the panel can mute themselves and maybe turn off their cameras so that we can have a little more bandwidth. I'm going to start this out with a sort of general question for everybody. We've heard a lot of things that lead to misdiagnosis and delayed diagnosis, a lot of causes and solutions or proposed solutions for the cases that were presented. I know we had to go through them all quickly, so I just want to make sure that see if anybody has anything they want to add to the list in terms of causes and important factors on these two cases. And that includes you, Hardeep, if there are thoughts that occurred to you about these cases that you would like to bring up. Let's see, Margaret and Hardeep and Nagwa, you are on mute. You should be unmuted.
Yeah, Helen, I'll start very tragic, obviously, cases. And, one of the problems we see is there's so many different types of not only conditions, but different types of reasons. And everybody wants sort of like one solution for the problem. A lot of people who ask me, well, can you tell me like one thing we can fix and that'll fix the problem? I'm like, no, there isn't. Because you really have to fix the health system, and you have to fix a lot of issues with clinicians and the interaction and the teamwork and the processes of care. And so what I think we're sort of, it's, even though there's multiple factors and there's multiple solutions, and all of them have to be done together.
So one of the things that I see, Hardeep, is patterns in all these stories. And so many years, and I see Margaret nodding. Yeah, we've talked to so many patients all over the world in so many years, and there are patterns. There are distinctive things that show up, and the big one is uncoordinated care and failure to listen to the family, or in both of these cases, there was also failure to listen to the nurses. So, just not having a proper team with the people who are closest to the problem.
Yeah, and some of these are sort of, I would say, training related factors that we just sort of like, we probably don't get enough of this. But one of the things we've been trying to do in our work is figure out how we can give more feedback to clinicians, both positive and negative, right? I mean, we can't always be telling people, oh, well, you missed a diagnosis. We should be giving feedback. So we need to build better feedback pathways about clinicians' own diagnostic performance back to the clinicians. The problem is, a lot of people that we talk to, they say, well, where do we have the time to go and sort of learn about this feedback? Because all physicians are seeing patients, because at least in the United States, they get paid accordingly, right? So they're seeing patients throughout the day. I think in UK, probably it's similar, that you're just seeing patients throughout the day. Where is that time for listening, quality improvement, debriefing, discussing difficult cases, learning from diagnostic errors, learning from feedback, talking to your peers around, sort of maybe some challenging cases or things that went wrong. That quality improvement, that safety improvement time is not built into our clinical activities. So we have a lot of physicians who say, we want to do this stuff, but we don't have the time to do it. Sort of a challenging issue. That's why I say we have to fix the health system too. Yeah.
Margaret, did you have a comment?
I did indeed. I think a lot of it gets down to the education, and I certainly put a lot of my own efforts into presenting to undergraduate students, postgraduate students, and people who are engaged in continuing professional development. And I particularly love to engage with the young medical and nursing students, because to me, they are the future of healthcare. And if we can change their, if you like, worldview, and if we can change how they look on things, it means that the culture will change. And a lot of the difficulties around the diagnostics are cultural, because people thinking there is this thing we sometimes call the God syndrome. And if a patient or family member questions something, they're often given the doctor here. And that kind of pushback is both disrespectful and it's not helpful. So there's also the point then about the vulnerable patient. I remember having a fractious conversation with one clinician, and the man was positively insulting. And Kevin was witness to that, wasn't part of it, but he was witness to it. He was the patient in the bed. And when that man was leaving the room, Kevin looked at me, his mother, and he said, "Ma'am, he's a nice man. He didn't really want to see the doctor upset because he saw him as the person, as his savior, if you like." And that is the huge vulnerability of the patient.
Yeah. Thank you, Margaret. That's a great point. Hussein, do we have questions from the chat?
Yeah, I have sent you those questions in your inbox.
In my chat?
Yeah,
okay.
So they are all together.
Helen, I see Dr. Arora has his hand up.
Oh, okay. Dr. Aurora, let me see if I can unmute you. Oh, can you unmute yourself? There you go.
Okay, thank you. Actually, I like to say that the most common error in diagnosis, what I have noticed is in labeling error. See, while taking a sample, when types the test request form and the name on the tube may different. And moreover, one more is that is the patient using single name. Just for example, if I say the name of Hussein Zafri, if the patient uses only Hussein, there can be 2, 3, 4 Hussein on the same day. But if you use dual name, there will be less error. While the test may be correct, the report may be correct, but while delivering the report, the patient may take the report of a different person. And at the moment when it goes to a physician, it says it's quite different. So the labeling error is a very common error. That I like to comment on that. And secondly, one more thing is there. Nowadays, there is a practice of having so many tests in a package, say all LFT, KFT, lipid, vitamins, and all these things. And many times while looking at the whole reports, you may miss an important report which has been noticed at that time. So the patient, doctor may miss that particular test report or that parameters, and that can be missed. That two things which I have noticed in practice happening in the. Thank you.
Thank you so much, Dr. Arora. We are running out of time very quickly. There's one question that I see Helen Hughes has put in the chat, and a number of people had asked this earlier, was how many people have actually adopted your checklist, Hardeep, and how likely do you think people are to respond well and actually implement all of these patient-friendly changes?
Yeah, great question. So right now, the checklist is available open access to everybody. It's easily accessible, which is what I'm trying to say. It's free. However, there's no mandate for any hospital in the world to adopt this checklist. There is no incentive for them to do it. So in Washington State, for instance, there was a very sort of strong champion who wanted to implement this across all 100 plus hospitals in Washington. She sent the checklist. Only 11 hospitals returned the checklist items back, and because there's no mandate for them to do it, right? So unless there is some clear policy guidance for health systems, or there's some type of an intrinsic motivation that they feel that they have to do it. So I've done it with sort of friends of mine, right? So I'll work with some health systems and outpatient practices to do these, but I would say the adoption is very low and very early. It's a classic, slow adoption, and it'll probably take a while, and it'll probably take some sort of a mandate or a structural. If it becomes a structural measure for hospitals, they'll do it. Otherwise, they won't do it. It's unfortunate, but that's a real story.
That is a very good point. And I think we are out of time. We have other questions in the chat. We will try to get them to you, our excellent esteemed speakers, and maybe you can answer them by email. Hussein, can you say a few closing words and close us out?
Yeah, thank you, Helen. And I'm sure that today's workshop, must have been educational and inspirational for all of us. We now understand how big is the burden of diagnostic error and how they impact the patients, the community, the society, as well as the healthcare systems. We've also learned that patient engagement plays a vital role in mitigating diagnostic errors by leveraging the unique knowledge, perspective, and experiences of patients. Collaborative decision-making and open communication can definitely significantly enhance the accuracy and quality of diagnostic processes, leading to improved healthcare and patient care. So thank you very much to all of you taking this opportunity. I really want to thank all the people who have attended today's workshop. My special thanks to Helen for presenting and also leading this workshop. Thank you. I'm also very grateful to Hardeep, who is a leading academic and expert in the field of diagnostic error. Your presentation has been very educational. Thanks for highlighting the importance of active patient engagement in the diagnostic process. My many thanks to Margaret, for your inspiring case study. I know Margaret for nearly 2 decades, as for the first year of patient safety network. And I'm also grateful to you, Nagma, for your presentation. Nagma, as you know, has been a patient safety champion and has been one of the the leading patient advocates in the Ambro region. If any one of you would like to be included in WPA's patient safety work, please email us and we would love to have you on board. They're just 2 short announcements before we close the workshop. WPA will be running a very big campaign on World Patient Safety Day, which is in September. And we are going to announce events grants that you can apply for and organize your events. And by the way, in the last 2 years, WPA has organized over 1,200 events during the World Patient Safety Day month, which is September. So please, join us. And the second announcement is about our regional meeting, which is for the Asian continent and the Australian continent. The meeting will be held in Dubai, 4th to 5th of November. This is going to be a hybrid event, so you can participate both in person as well as virtually. Registration is totally free. And there will be grants available for you to participate in the Dubai meeting as well. So, so we will be sending out the, a meeting invite soon, so you can apply for these grants. And yes, certificates of participation will also be sent to you very soon. This presentation and as well as the recording of the workshop will be available on our website. And lastly, I would like to say that would like to ask you to become member of the World Patient Alliance. It's totally free of cost. You just need a short, you just need to fill up a short online form, and that's it. So our website is given over there. So we really look forward to having you on board. And the last, thank you once again for participating in the workshop. Thank you very much.
Thank you.
Bye-bye.
Thank you.
Thank you, everybody.
Thank you.
Thank you, Hardeep. Harris, is it possible to save the chat?
Yes, we can retrieve the chat.
Thank you. Yes, we have all the questions in there.
Okay. Thank you, everyone.
Thank you. Thank you. I thought I was very pleased. Thank you with everything you did.
Oh, thank you. Thank you so much.
I know it wasn't easy to
But
get
you know
through.
what? It's a very good workshop, but it's very short for the subject.
Yeah, yeah.
Say we
It
should
should,
probably do another one.
It should have been 90 minutes.
1.5 hours or 2 hours minimum, because
I
everyone
don't know why we didn't think of that, but yeah, it should have been 90 minutes.
next time. Okay, bye everyone.
Okay,
Bye,
bye-bye.
and God bless. And keep up
Bye-bye.
the work.
Thank you so
Bye,
much.
Margaret. Nice
Everybody.
to see you. Bye, Hussein.
Bye-bye.
Bye-bye.